Bupropion. The name brand is Zyban. Learning objectives. By completion of this activity, participants will be able to describe the properties of bupropion, list its advantages and drawbacks, describe availability, cost, and coverage, explain standard and alternative dosing recommendations, and list common side effects and mitigating strategies. In overview, bupropion is an effective pharmacotherapy for smoking cessation and is also used to treat depression. It's thought to act by enhancing the central nervous system noradrenergic and dopaminergic release, which is essentially the brain's reward system and the way that nicotine works. The advantages of bupropion are that it is safe for use in smokers with stable cardiovascular disease, whereas we saw some significant possible problems with varenicline with cardiovascular disease. And it's also safe in patients with COPD, whereas we saw that the nicotine inhaler can cause bronchospasms in those patients. It's safe for smokers hospitalized for acute myocardial infarction. So this is presumably an unstable cardiovascular disease, a population where there's been concerns with the use of varenicline. However, in the study that did prove that bupropion was safe, it did not prove that bupropion was effective for helping people quit. Another advantage is that bupropion temporarily blunts the post-cessation weight gain, and this can be a good choice for smokers who are especially concerned about weight gain after quitting smoking. The major drawback is that it lowers the seizure threshold, so anybody with a history of seizures or a high risk for seizures it's contraindicated to use this drug. This Zyban or bupropion is available only with a prescription, and the cost is approximately $4.30 a pill if you don't have insurance, which means $8.60 for the 2-pill dose per day. Coverage. The Affordable Care Act requires that all Medicaid programs cover all tobacco cessation medications beginning January 1st, 2014. And bupropion is covered in all 50 states. It's not covered in the District of Columbia, and its coverage varies by health plan in the states listed. The standard dosing. Smokers are instructed to quit 1 week after starting bupropion, by which time there are stable blood levels achieved. This is what we saw with varenicline, where a week was needed to achieve stable blood levels. And the way that this is done is starting at 150 milligrams once a day for 3 days, and then 150 milligrams twice a day thereafter. The recommended duration is a minimum of 12 weeks. A lower dose of 150 milligrams per day instead of the 150 milligrams twice per day is an option for smokers who do not tolerate the full dose due to side effects, and 2 randomized trials have found that the 150 milligram per day dose was as effective as the 300 milligram per day dose and associated with fewer side effects. Now, it's possible that longer than 12 weeks is effective for people who have successfully quit. So one study compared continuing bupropion for a year after someone had successfully quit to stopping it and switching them to a placebo after they successfully quit. And it was found that at 1 year, the abstinence rate was higher if they continued the bupropion for that year, 51 versus 42%. And after they stopped the therapy or the placebo at 1 year, and they looked 16 weeks later, there was a higher abstinence rate, 47 versus 37. If people relapsed, the time to relapse was longer in the group who were receiving bupropion for 12 months, 156 days until relapse versus 65 for those on placebo. And the weight gain was less at 2 years, 4.1 kilograms versus 5.4 kilograms. However, probably the most important result was that the abstinence rate at 2 years was the same in both groups. So perhaps the only clear advantage at 2 years is that people will not gain their weight back to the same degree, but they'll still be as likely to have quit smoking at 2 years if they continue the bupropion for a year versus 12 weeks. So there are, and just like we saw with varenicline, post-marketing case reports where this drug was associated with increased risk of suicidal, self-injurious behavior, or depression. And these risks were smaller than those observed for varenicline, but greater than those seen in patients taking nicotine replacement. And a randomized trial comparing bupropion, varenicline, and the nicotine patch with placebo actually found no difference in adverse neuropsychiatric effects. So, though the FDA had issued a black box warning for varenicline, it only advises, it doesn't have a strong recommendation. It only advises or a stronger warning for bupropion. In 2009, the FDA recommendation advises patients to stop the drug and contact their clinician's office if they or their family notice any unusual behavior or mood symptoms. Another way of preventing this side effect is having the patient monitored for neuropsychiatric symptoms, including changes in behavior, hostility, agitation, depressed mood, suicidal ideation, and suicide attempts. And that can just be done by letting the patient know to inform a significant other or loved one that these are the possible side effects and to be on the lookout. A follow-up or visit or telephone call is also recommended within a week to monitor for adverse effects. For the side effect of seizures, bupropion does reduce the seizure threshold. In clinical trials of bupropion for smoking cessation, the risk of seizure was 0.1%. However, the risk was dose dependent. So it most often occurred in the setting of an overdose or in patients with predisposing risk factors for seizures. The prevention strategy is simply not to prescribe bupropion in patients with seizure disorder or predisposition to seizure. The most common side effects are insomnia, agitation, dry mouth, and headache. And as we discussed earlier, consider a lower dose, just 1 pill a day instead of 2, for patients who are having these side effects on the full dose.